Hello everyone. Today I will be discussing about the antihypertensive drugs, okay, and their role in different circumstances, okay. And today I'll just be discussing only with the ACE inhibitors and ARBs, okay. So to keep the video really short, okay. So the thing is, this classification is not complete. Okay, I have not included the rest of the drug classes, so I'll be like putting them in my next videos. Okay, so the thing is with the ACE inhibitors, you know that one person comes with you with a history of hypertension, so you need to decide, you need to take a good history in order to give him or prescribe him a good drug for his hypertension. It depends. Okay, so the thing is, I don't know, but mostly the guidelines that is followed is from the AHA, American Heart Association for hypertension. Okay, so it varies from country to country. Okay, so the thing is with the ACE inhibitors and ARBs. So ACE inhibitors are the class of drugs, okay, that will help the patient to lower his or her blood pressure but will not affect the heart rate. This means that a patient who comes to you and he has like bradycardia, for example, beats less than 60 or 55, you can prescribe this drug without any problem, even the ARBs, okay, because this will help lower the blood pressure. The next thing, if a person doesn't have any history of hypertension and is newly diagnosed hypertension, okay, and depends, is it grade 1, grade 2, or grade 3 hypertension, depending on the grade. So you have to treat not with the ACE inhibitors instead. You have to use thiazide diuretics, okay, that's the first line treatment of hypertension, okay. But there are some things that we need to look forward in order to start the treatment. Okay, so with the ACE inhibitors, we have this thing. What effect do they do actually on the heart? When you prescribe a patient with ACE inhibitor, I told you it lowers the blood pressure. This means it decreases the preload and afterload on the heart. Okay, whatever it does more is like it helps in congestive heart failure patients with reduced ejection fraction. Okay, and even it can be used in patients who recently had an MI. Okay, even you can give this patient in diabetic nephropathy. Okay, so as you guys all know, the mechanism of these two drugs, ACE and ARBs, okay, the mechanism of these drugs is like they block the renin angiotensin aldosterone system. Okay, the function of this system, if I talk in basic sympathetic nervous system, okay, will help retain water and sodium. Okay, so what happens with this thing? This ACE inhibitors will block the conversion of angiotensin 1 to angiotensin 2. Okay, it will block the enzyme. So what happens when this angiotensin 1 is blocked from converting to angiotensin 2? So there are low levels of aldosterone. Okay, so this means there is less water retention. Okay, but the main disadvantage to this is this will increase the potassium ions. It will causes elevated potassium. Okay, and the next factor is when you prescribe these ACE inhibitors will let in the increased level of bradykinin, which will stimulate coughing in patients. Okay, and these ACE inhibitors and ARBs, they must be avoided in pregnancy. Okay, and if a pregnant woman comes to you with hypertension, as you know, okay, that thing is also of a detailed thing, but just to be on a superficial side, okay, if a pregnant woman comes with hypertension, so the drugs that we need to prescribe to her is not ACE or ARBs, as I told you. What I remember it from my time, I had a mnemonic from like USMLE. It says that he likes my neonate. It's hydralazine, labetalol, methyl-dopa, and nifedipine. Okay. The thing is, using these mnemonics will help you remember the drugs that you can give in pregnancy. Okay. So the next thing up, if you give this ACE inhibitors in patients, okay, The problem will be there will be increased potassium ions. Now, this will not happen frequently, okay, that the potassium ions will be increased, but the thing is, for example, an excessive potassium level of more than 5 or close to 4.5 or 5, okay, will lead on an ECG a peaked T waves, okay. So that's a different kind of story, okay. So let's not go in that detail, okay. So what happens with this one, ACE inhibitor, is the most important thing. So you have the drugs ending with pril, benazepril, captopril, enalapril, quinapril. Okay, it's with the ending with the pril. Okay, brand names will vary, A to Z. Okay, so the thing is, the drug captopril, this is an active drug. Okay, what I only give this drug to the patients captopril who does not have any liver disease, or if the patient does not have any um, cirrhosis of the liver or fatty liver, I would give this drug. Why? The reason is because this is the active drug. It does not need to go in the liver to metabolize. Okay. Whereas you have this enalapril, lisinopril, it's not mentioned here. Okay. The other drug ramipril and fosinopril. These drugs are prodrugs. Okay. Why they are prodrugs? Because they need to go to the liver in order to get activated. Okay. So the one thing that I know is fosinopril. Okay, that's not mentioned here. Okay, it's not excreted through the kidneys. All these drugs are excreted through the kidney, whereas fosinopril is not excreted through the kidney. Okay, fosinopril has got a balanced elimination. It goes out to the liver and kidney both. Okay, okay. So this is the thing that I want to discuss about the ACE inhibitors. Okay. So in the next video, I'll take myself to the ARBs, okay, and the next video with the calcium channel blockers and beta blockers. I hope you like this video, and if there's anything that I missed out, or is there anything that I need to add up, just do mention in the comments. Your feedback is really important. Thank you.